Hello everybody, welcome to Guest Room. Today we have with us Dr. Carol from New York University. She is specialized in trauma. Let's welcome her. Welcome Dr. Carol. Could you please tell us something about yourself?
I'm an associate professor at New York University School of Social Work. I'm also trained as a psychoanalyst, and my area of specialization is trauma, particularly social workers who are exposed to trauma.
Okay, could you please elaborate more on what trauma is?
Trauma is basically what comes out of the blue. Something is traumatic if it's unexpected, it's sudden, and one fears for their own loss of life. And there are many things that are traumatic in nature. I mean, we know in terms of domestic violence, we know in terms of war, immigration process can be traumatic for people. There are many things that really can be traumatic in one's life. And sometimes poverty itself can be traumatic.
Well, I believe you are into teaching as well. So could you please tell us the challenges that you face, while teaching the social workers?
One of the things that's difficult in teaching social workers is that we're trained, many of the social workers want to go into working with clients in direct practice. Some want to go into what's called private practice, where they work as if it's their own business. Many social workers want to do that. Many students want to do that. Many of them actually do, but our profession itself is really focused on working with vulnerable populations, so that you have basically students who want to learn one thing and our profession that really focuses on another. So the challenge is really getting people to make sure that their heart is in working with at-risk populations, populations in need.
Well, doctor, this question would be for our viewers. How do they recognize if they are having traumatic symptoms? If you could please elaborate on that.
There are some symptoms of trauma that are very direct, and they're of a couple of varieties. One is basically a re-experiencing of the trauma, so that one has the same kind of symptoms that they had when something was going on. And also something we call hyperarousal, which means that they have a startle response. So somebody who was served in the war, for instance, they come back home and a car backfires and they're responding as if they're in battle. And also avoidance. Some people avoid everything to do with the original trauma. The places, the sounds, the sights. And when you avoid those, what happens? You end up reinforcing the symptoms because there's no chance to extinguish them. Now those are the primary symptoms of trauma. Then you have something called secondary symptoms. This is especially important for your viewers because a lot of times people may have depression. They may suffer with alcohol or substance abuse. They may have an eating disorder. They may have a lot of anxiety. They may have some symptoms that aren't necessarily characteristic of trauma per se, but they're what we call secondary responses. So it becomes the way the person tries to self-medicate from the symptoms of trauma, from the primary symptoms of trauma.
Okay. And when a person, approaches you, what is it that, how do you actually tell him that you are suffering from trauma and you're very much there for the person to help him? What are the reactions like?
Well, I think what's most important, first of all, is you want to understand what the person went through, because they might have gone through something that's traumatic, but they don't identify it as such. The most important thing you can do for somebody is to normalize their experience. So in other words, it's not that they're abnormal. They were in an abnormal situation and they have a normal response to an abnormal situation. How often do we go through every day where all of a sudden we're confronted with possible death? That's traumatic. So that they have to understand all of the reactions they have, the anxiety and everything else is in fact normal.
Could you please also tell us something about your research?
My area of interest is clinician-based trauma. And that grew out of my own experience during 9/11, where I was sitting with a patient when the plane flew over the building. And you could hear the plane hit the towers. You could hear everybody reacting. So I was so struck by that. And my patient and I did not know what was going on. So I said, I wonder what other clinicians experience. So I started my research project looking at clinicians who lived in Lower Manhattan, lived and worked in Lower Manhattan, and what their experiences were like with their clients. So I actually work on something called shared trauma. that's when a clinician, see, if I were working with you and you were traumatized, but I wasn't, but you're telling me a traumatic story, let's say you're telling me a horrific story of how you were raped, then I might get traumatized by listening to your story because it's very scary, right? Anybody, helpers can get traumatized.
Okay.
Anybody who's a support system for someone who's traumatized can get traumatized by hearing that story. But what happens in shared trauma, what happens if I'm exposed to the same collective trauma you are? We're both sitting watching the plane. So in fact, it's a different experience for the worker because they're traumatized as well in a primary way. So from my research with 9/11, I then also did a study with Hurricane Katrina. And then I've done consulting work for other areas in Yogyakarta, Indonesia. I had done some work because a lot of the people were victims of the earthquake, which is a big problem.
Yes.
And I've done, consulting work for other places as well.
So, doctor, what do you think does a traumatized person face the biggest challenge by the society?
One, I would say, is first of all the stigmatization around it. So a lot of times the person feels stigmatized because they're given a diagnosis, a DSM diagnosis of trauma. So they feel as if there's something wrong with them. So that's one of the biggest challenges that people face. People who are traumatized but have social supports fare much better than people who don't. So it's really important to have a support system that totally understands. There's certainly been situations where people have faced horrific things that aren't acknowledged publicly. A good example was with the Vietnam War. Many of the soldiers came back and they were traumatized, but it wasn't a society that was accepting of them. And so they really had nowhere to go with it. Whereas now we're much more informed about it. And there's really an effort, at least in the U.S., to really acknowledge it in the military.
Could you please tell us something about international social work?
Well, international social work, it depends on who you ask. So from our perspective...
Yes, from your perspective, from the research area of trauma?
Certainly in the United States, and what we do at New York University is we try... we have campuses in Shanghai, for instance, Abu Dhabi, and we try to be culturally sensitive. Any populations we work with, we try to be very respectful of what the culture is. But most Western countries have to really fight against the tendency to colonize their understanding and brand of what social work is and bring it to other countries. So that's something, that oftentimes people will do that's not helpful to a particular culture, because then it becomes more hierarchical and you become the expert who really doesn't know the culture in an indigenous way that's really necessary. So it's best when somebody comes from outside and partners with the national, and that's research and everything else that works well. One of the projects I was involved with as a consultant was really involving Afghanistan. They didn't have social work, was not a formalized profession. So I was involved in that process. I was a consultant to, there was a grant by other people from Boston College and Hunter College School of Social Work, and they had a grant, and I went in and was involved in it as a consultant, and we really helped them develop the curriculum for, now there is social work in Afghanistan.
So could you please share us more experiences of your work there?
Well, I was just there just for a couple weeks, so I was there very briefly, and I worked on developing the documents that are necessary from which it dovetails with the curriculum. It was basically the job test of what a social worker does.
Okay.
Others had done the research, and it was basically kind of writing that up, and that's the guideline by which social workers then would go about doing their job. But there are many people who serve that function in an NGO capacity or were trained by an NGO, but not really as a profession. So that was one of the things that I played a very tiny part in, that I was just proud to be able to do.
what exactly do you think are your personal satisfactory level or your rewards that you have gained in the area of your interest, trauma? If you could elaborate.
Well, one of the things that I would say to anybody who's interested in social work as a profession, because many of your viewers maybe had a curiosity about what a social worker
does. There are many
does,
people who are actually ready to extend their support in possible ways.
I would say the first thing you have to keep in mind is that social work is a calling, in the sense that you have to really feel like you're compelled to do it, that you get tremendous joy from helping others, so that's its own remuneration, its own money. Very few people actually make much money in social work, so that's not going to happen. So one, they have to love it, and then also is a lot of times it's not unusual that people go into the field, come from families or problem areas that they have in their background. Sometimes there may be trauma in their background, or substance use or mental illness in the family, and that in a lot of ways social workers, in helping others, you help yourself and understand yourself better.
So do you, like you just said some time back, do you also feel that the social workers who are extending their support also feel traumatized?
Yes.
And how is it that you help them come out of it?
Well, basically, you have to, it's like the preacher who preaches, you have to be able to do what you're telling other people to do.
But sometimes, after all, they're also human beings.
Exactly. So the most important thing is that people get self-care. So the very advice we're giving to our clients, we need to take ourselves in terms of making sure that, we have a life. When people say, how do you prevent burnout or secondary trauma? I say you could summarize it in 3 words: have a life. If you have a life, then you have people outside of your work that give you pleasure. You have activities that replenish you. You need to be replenished in order to do the work, because it's very draining.
It is indeed. Could you please tell us about your research topics?
Yes, my area of research is what's called shared trauma, and I've had a number of journal articles on the topic. And we developed an instrument to measure it. And that's from my work with Hurricane Katrina, people from 9/11, as well as other consulting work I've done. But my publications, we did training video tapes based on shared trauma. Let's see what else to tell you. And just a lot of publications. And I've co-edited 3 books, so I've done a lot of different things.
What are the 3 books that you've co-edited?
Well, it shows just an evolution of my interests. First one was basically on something called love and attachment, and looking at contemporary love in terms of attachment theory, because I'm a psychoanalyst by training, so that started from that. A second book was really around short-term treatment, because a trend in our field now is that insurance companies don't reimburse for long-term therapy. They're really only reimbursing for short-term evidence-based therapy. So it's how you can infuse the long-term principles of the focusing on the relationship and everything else in short-term work. And then the third one is basically is looking at how the importance of the environment in doing clinical work and how it could impact the therapeutic relationship.
So what do you think is the best possible solution that you could give to a traumatized person to upbring him, maybe to help him in any which ways possible? What is the best solution according to you?
The best solution, first of all, is to recognize that what they're experiencing is in fact trauma-based. There's wonderful supports available for it that we know work. EMDR, eye movement and desensitization and reprocessing. There is exposure therapy. There's a lot of fabulous therapies, narrative exposure therapy, a lot of wonderful therapies, just trauma-based that we know for fact work. So you would want to basically educate them, 1, that it's a normal process, and 2, that with help, they can diminish those symptoms so that they're not kind of hostage to those symptoms.
So does the time of recovery vary for every person, or do you have any categories for that as well?
Well, everything's individual, so that there are some people who might have experienced a traumatic event and they're very resilient. They get over it, it's not a problem. And someone else who had a minor incident that is still dealing with the trauma many years later. So there's these individual kind of constitutional factors that play a part in how somebody's going to respond to trauma, as well as the cultural context, the degree of support from family and friends, how important religion is to them, and whether or not that serves as a source of solace. So all of these factors come into play, so it's really difficult to say. There's only really about 10% of people, more women than men, who are actually develop PTSD, post-traumatic stress disorder. But many other have what we are called subdiagnostic PTSD, meaning that they have some symptoms, but not enough to diagnose them with it.
Even the kids are prone to this?
Sure, kids are prone to trauma, absolutely. But with children, it's a little bit different because some children don't have the, depending on their age, the verbal ability, the verbal fluency to really say, I've been traumatized, here's what I experienced, here's what I went through. In many ways, you have to understand the nature of trauma. People talk about trauma being like a speechless terror, in the sense that the way trauma is processed, it's not normal memory.
Do you have any message for our viewers?
I think that's kind of the message in a way. One thing about social work is that you work kind of with the horrible problems and you help people, and what's great is to see people get better so that you know that hope is possible, you know that people change. It's really belief in the system, a belief in the importance of a relationship to help somebody. And so that's really kind of the takeaway, that there's always hope, there's always renewal, and there's always resiliency. And that's what people tap into after trauma.
Thank you, Doctor, for your time and valuable inputs. We really had a pleasurable time talking to you.
You're welcome.
Until we meet for the next time, this is Chitra signing off.